I've given this as Allison said, a couple of times, and I don't know how many repeat customers are here, but some of them are redundant, but the whole field of cardio-oncology is relatively new in the last 5 years, and there's a lot of information and investigation into cardio-oncology and the way the heart responds to not only cancer, but chemotherapy. It's a growing issue, a growing area of interest because there's so many people with cancer. 15 million people survivors in the U.S. and 20 million by 2026. And there's actually programs in cardiology training centers that have fellowships in cardio-oncology. Next. So really, we're talking about three major cancer therapies. Probably the most common cancer therapy is chemotherapy. And, this includes intravenous and pills for everything from breast cancer, prostate cancer, leukemia, you name it. But, most of these are agents that interfere with metabolism of the cancer cells and interfere with cell replication and all kinds of different mechanisms. And the side effects can affect numerous parts of the heart, which I'll talk about in just a minute. The other part of it is radiation therapy, which is also common, but probably not as common as chemotherapy. But this is all, the people who get radiation in their chests and their breasts and prostate and other areas. Excuse me. And then the third area is a little bit of a newer area in the last maybe 5 to 10 years. And this is the immunological therapy, checkpoint inhibitors, and a lot of the new kind of exciting part of oncology that has all kinds of new applications and great results in a lot of cancers. Next slide. So, the most common thing that we see in terms of side effects to the heart is really the heart muscle. We call this cardiomyopathy. And probably the most common drugs that we see or that are famous for this are adriamycin, which is used for breast cancer, doxorubicin, and Herceptin. And there's a couple other ones, but the oncologists are very aware of it, and they're very careful about not giving more than a certain amount and monitoring for side effects. But that's probably the most common thing that we see. Other things that we see are electrical problems, typically atrial fibrillation. It's pretty rare to find like heart block where you need a pacemaker, strictly from chemotherapy. Heart valve problems are pretty much entirely from radiation. You don't see that much from chemotherapy. And most of that radiation occurred maybe 20, 30 years ago when they were using much larger quantities of radiation. And they didn't screen at the time and focus the beam that would protect the heart. They used to give these mantle radiations for, especially Hodgkin's, who get the whole mediastinum. It would just radiate the lungs and the heart. So we don't really see that anymore very, very commonly. Coronary disease is so prevalent in people, as they get older that it's just endemic in the population. Oftentimes made worse with chemotherapy. High blood pressure, again, is so prevalent in all people, not just cancer patients. It's another very, very common problem that we see. Blood clotting problems are also more common, and especially certain kinds of chemotherapy. Again, it's not all that common. Clotting in veins usually results in blood clots going to the lungs, pulmonary embolisms, which is can be very dangerous. But again, most of the drugs it causes are monitored pretty closely by the oncologists. Strokes and heart attacks, I'll have to say, is quite rare. I can't remember the last time that I saw a stroke or heart attack from chemotherapy. It's been reported, it happens, but you just never see it anymore. Pulmonary hypertension is, again, a side effect that you see from the lungs getting radiated usually. Very rarely some chemotherapy can do this. And pericardial disease, again, is quite rare. And almost exclusively, we see this from radiation, and especially in the old days. Next slide. Again, I mentioned heart muscle damage. I mentioned anthracyclines, adriamycin, Herceptin. And then typically the oncologist will get echocardiograms or ultrasounds regularly, like every 3 months. Occasionally they'll check blood work, troponin measures muscle damage, EKGs are used. We don't really use much nuclear imaging for this because echoes are so much easier to do. There's been some interest about starting therapy for heart muscle damage before you even give chemotherapy. That really didn't show any benefit originally, but there was one recent trial that did show that patients who start getting chemotherapy with a cardiotoxic drug may actually benefit from a low dose of a beta blocker and an ARB, which we'll talk about. Next slide. Treatment is similar to what we treat for people with garden variety cardiomyopathy from viruses and hypertension, and pretty much involves beta blockers, ACE inhibitors, angiotensin receptor blockers, and Entresto, spironolactone. These are all drugs that we use for heart failure. Occasionally, people need diuretics. Next slide. Coronary disease, again, is so prevalent that we pretty much treat it the same as we treat it in everybody. So, some people need angiograms and stents, some people need bypass surgery. Don't really see it caused specifically by chemotherapy. It's typically an exacerbation or a manifestation during chemo that we see in someone who probably has already had it. So if you don't really have coronary disease, I don't think you're going to get it from chemotherapy that quickly. It really takes decades to build up coronary disease. Other risk factors like high blood pressure, cholesterol can be made worse with certain chemotherapy. Next paragraph or next slide. I mentioned this before, valvular heart disease. Again, it's treated like any valvular disease. Most patients who present with valvular disease with chemo or radiation have had it before. It doesn't just show up overnight. They probably had this coming on for decades, years. Next slide. Arrhythmias, again, we see it commonly. Atrial fibrillation is so common that it's sometimes hard to know if it's from chemotherapy or just from natural progression of age and cardiac disease. Next slide, please. High blood pressure, again, so common that it's hard to say whether it's from the chemotherapy or just natural history. Typically, there are certain agents that really cause high blood pressure, and oftentimes they'll have to stop the blood pressure medication. Next, we're going to answer questions at the end. So, blood clots, again, not that common, but can happen. Next. Pulmonary hypertension, again, pretty uncommon. Haven't really seen that for several years from chemotherapy. Next. I mentioned this pericardial disease, again, very rare. I haven't seen it in many years. Next. So how do we monitor people with heart disease getting chemotherapy? Really, echocardiography or ultrasound is really the gold standard. It's the workhorse. It's non-invasive. It's ultrasound. It's relatively inexpensive. It's easy to do. It's portable. You can get multiple studies over a period of a year. Lab tests, the troponin has been used. Something called the brain-activated peptide is occasionally used to monitor cardiotoxicity. Usually the oncologist order these. Next. So that's it. So that's kind of covers A to Z, cardiology, cardio-oncology. And now I'm more than happy to answer any questions from anybody. What are the long-term side effects of carboplatin and Taxol? This is something that you might want to talk to your oncologist about. They typically use different doses and they pick those drugs for certain reasons. Actually, Taxol we use also in stents. So it's I think it inhibits the mitotic replication site of the cell, so it prevents cell reproduction. So it inhibits certain cancers. So we use it as a coating on stents. When we put stents in the artery sometimes forms a scar tissue and it grows into the artery again. In order to inhibit cell growth within the stent, we give these drug-coated stents. Paclitaxel is the original one. It's called a Taxus stent. Now there's like third and fourth generation drug-coated stents.
One question that I did receive is, should there be any pre-existing cardiac conditions that would negatively interact with chemotherapy?
Yeah, that's a very good question. So if you have had heart failure in the past, and that would include like a big heart attack with a bad heart muscle. So the, how do I call it, the way that we define kind of the heart muscle function is with something called the ejection fraction. And I see this person asked the LVE, and actually the left ventricular ejection fraction. And it's basically kind of a universal currency, I'll say, of cardiologists and doctors and oncologists. And it looks at the amount of ejection of the heart. So when the heart pumps as a pump, it doesn't pump to zero. So it doesn't go to squeezes to zero. The heart pumps kind of like this. So what we do by echocardiography is we measure the volume at relaxed phase, we call that end diastole, and then the squeeze phase, that's systole. So we subtract the volume from relaxed to squeeze and divide by relaxed. So that's called the fraction. So the normal ejection fraction of a normal heart is about 50 to 65%. That's how much blood is ejected from the heart. When the ejection fraction goes below 50%, that's a diminished heart muscle function. Usually like 40 to 50% is mildly depressed, like 25 to 35%, maybe 40% is moderately depressed, anything under like 25% severely depressed. Anything under 10% is like critically depressed. So if you're going into chemotherapy with an ejection fraction of 30%, and that's not 30% of normal, that's an absolute number, then you have to be very careful. So you can't really use adriamycin or doxorubicin, and Herceptin is probably going to be off the table. I hope that kind of answers your question. Does that answer your question, or?
Yes, it looks like it did.
Okay.
Another question that we received, I'm going to ask this question and then we had another question. The first one is, I finished a 6-month course of Folfox in March 2020 and started to experience PVCs in October 2021, which is about 1.5 years later. Any chance that would be related to the chemo?
Again, I don't know that drug. I don't use these drugs, so I'm not probably the best person to ask. You should ask your oncologist, but it's possible that some of the agents can have lasting effects. So I'm going to have to say possibly, and your doctor may want to order like an echocardiogram, because some of these drugs can, have effects on the heart that are long lasting. You can get scarring of the heart.
Along those lines, would you recommend consulting with a cardiologist after completing treatment as kind of a standard practice, or only under certain circumstances?
Yeah, I think that's usually only under certain circumstances. I would say that the oncologists are really skilled at what they do, and they really know when to get a cardiologist, and they're usually pretty quick to get one when they need one. And oftentimes, they just pick up the phone and say, hey, can you, this is what I have, what do you think? And can you see this person? We get him in right away. But I don't think everybody getting chemo has to see a cardiologist. I think that would be a little overkill.
Thank you. Another question that came in is, one of the slides mentioned aspirin as a treatment. Recently in the news, daily baby aspirin is now not recommended. What should we believe? Very
good question. So historically, if you go back to the 1980s, a lot of the studies on heart attacks and strokes were coming out. And at the time, it was apparent that aspirin was very beneficial in inhibiting platelet activation. Platelets are the little sticky things in your blood that causes your blood to clot. And, you know, a heart attack or stroke is actually where the inside lining of the vessel has a rupture, activates platelets, which are the little sticky things, and then causes a blood clot, activates blood clotting products. So aspirin is very effective in inhibiting platelet activation and preventing blood clotting, especially after a heart attack or stroke. So there were all these studies. There was a huge, you know, series of studies called the TIMI trials, blood clot thinners and you know, streptokinase and all these different drugs, and almost all of them looked at blood clot. And aspirin was found to decrease the risk of a future heart attack or stroke by maybe 20, 30%. So anybody who had a bypass surgery or a stent or a heart attack or stroke, all those people should be on an aspirin. At the time, it was felt that, well, you know, if it's good for those people, maybe it's good for everybody. And so it kind of came out from anecdote and from like people's like common, I'll say common sense, but not science, that, well, maybe where people start having heart attacks and strokes, maybe everybody who's age 50 and over should take a baby aspirin, because it's a relatively safe and cheap drug that has, you know, very little side effects and doesn't cause any harm. So from that time on, you know, everybody age 50 and over, you know, been getting aspirin like candy. And if you go back and look at that, those people who have been getting it now, it's been, you know, 30, 40 years of this practice. About 3 years ago, the European Society of Cardiology did this huge, you know, database investigation, and they looked at all these people. And what they found was that aspirin's really not all that benign. And when you give it on a population basis, and you're giving like, you know, hundreds of thousands of people aspirin, there's going to be a certain number of those people that are going to have side effects that can be very dangerous, including intracranial bleeding, a hemorrhaging in the brain, and a GI bleeding and hemorrhaging and death. So they looked at all those people, and they found out that the people who have had heart attacks and strokes and stents and bypass surgery definitely benefited from the aspirin. But if you've never had a heart attack or stroke and you have absolutely no heart disease, the risk of the aspirin is actually greater than the benefit. So you should not be taking an aspirin if you've never had any heart disease. So that's what you're reading in the newspaper now. Do not take an aspirin if you don't have heart disease or have never had a heart disease. Now, I'm going to have to qualify that by saying, what about the person who has heart disease but has never had a heart attack or a stroke? Well, how do you know who they are? And you don't. Basically, you don't.
Well, your brother should stop his aspirin.
What's that? Oh, let's see. So I'm going to just.
I'm sorry, I didn't silence. Sorry.
Oh, okay. So I'm going to take this one step further, and this is what I do every day. Is people come to see me and they say, "Gee, Dr. Roth, what's my risk of a heart attack?" And one of the tools that we use, besides, you know, treadmills and blood work, is something called a coronary calcium scan. It's basically a very low radiation CT scan of the heart, looking for calcified deposits in the arteries. That correlates with atherosclerosis, or hardening of the artery, or plaque buildup in the arteries. So if you have a score of 0 and you're like 60 or 70 years old, your risk of a heart attack or stroke is extremely low. If you have a score between 0 and 100, you have a mild risk. If you have a score of 100 to 400, you have a moderate risk, and anything over 400 is a high risk. This is all based on studies from something called the MESA trial, which stands for the multi-ethnic study of atherosclerosis. And I don't mean to get way off on a tangent, but this is my bread and butter. People with a lot of calcified arteries who have a lot of plaque are at risk for heart attacks and strokes. So currently the guidelines are, if you have a score of over 100, we do recommend a baby aspirin. because it's no longer what we call primary prevention, meaning you haven't had an event. It's now secondary prevention. You have heart disease. So I put almost everybody who has a calcium score of over 100 on a baby aspirin, and I put them on a statin or a cholesterol medication. So I know you asked kind of a simple question, and I answered it with a very complex answer. So I hope I didn't lose anybody with that. But it's not an easy answer to say whether or not people should take aspirin or not.
I have a question.
Sure.
How common are heart problems from Herceptin, and what would those be?
Yeah, so Herceptin actually, unfortunately, is quite common. And I'm not sure I can give you the exact number, but percentage, but I know that the oncologists screen very, very carefully before starting Herceptin. And oftentimes, if the patient's a little bit too old and at risk for heart disease, they won't use the drug. And a lot of times they'll send them to me to do a series of tests like a stress test and echo. And then if anything comes back abnormal, then they'll try to avoid Herceptin. But Herceptin is one of those drugs that we worry about a lot. It's not a benign drug. It's one that can be associated with cardiomyopathy. And I'm going to guess about 30% of the time.
And so that would mean that your heart muscle just doesn't pump well enough, or what?
Typically, if your heart muscle is not pumping well, they'll probably won't give it to you to begin with.
Yeah. No, I mean, if you get cardiomyopathy, I mean, what is that? Is that before a heart attack? What is it?
Yeah, so a heart attack is when an artery has a ruptured plaque and has a clot in it, and then the muscle dies over a period of like 4 to 6 hours. And with severe chest pain, and you put a stent in that, that's very different than cardiomyopathy. Cardiomyopathy is basically cardio is heart, myo is muscle, and pathy is disease. So it's heart muscle disease. So basically the muscle degenerates and deteriorates. So it's a kind of a global destruction of heart muscle. It is reversible if you catch it early enough and if you give it the right drugs. So typically, I read a lot of echoes, and the oncologist, I'll see the same patient echo, and not the patient, but I'll see the echo over and over every 3 months, and I'll, make a comment compared to the last echo, the ejection fraction is the same or it's fallen. If it does fall, I usually call them right away. I call the oncologist and say, hey, so-and-so's echo looks different. I just want to give you a heads up. And they say, oh, great, thanks. So it doesn't happen overnight. It takes months to happen. And the oncologists usually follow it, with serial echoes and EKGs and stuff. And if it does start falling, I think if there's more than, I think, a 10% fall in ejection fraction, they'll usually either stop the drug or cut the dose back or use an alternative drug. And at that point, we usually start the beta blocker, like the carvedilol and the Entresto or the ACE inhibitor or whatever, or spironolactone. I'd say more likely than not, the majority of people get better with the medications, that the heart muscle comes back to normal.
Huh. Okay. And then what's there's, I think it's a scan, a MUX
a nuclear scan, MUGA scan or a nuke scan.
MUXA, yeah. What is that?
It stands for multi-gated acquisition scan. We used to use that a lot, like 30 years ago. It's an isotope that's injected into the vein, and then the heart's visualized on a gamma camera that looks at the heart pumping. It's like a glowing ball that moves, and you can calculate the pixels, you can calculate the relax versus the squeeze phase and come up with an ejection fraction. We don't use that anymore very much because it's a little bit antiquated and it's radiation and it's expensive. So the echocardiogram gives you all that information and more.
I see.
We do use a lot is the MRI, which is a magnetic resonance imaging. The nice thing about the MRI is it's exquisitely accurate and very precise. and there's no radiation. It's all magnet. The downside is it takes like, an hour in the tube with, claustrophobia. It's not good. And it's very expensive. So, most people really stick with the echocardiograms.
Okay, thank you so much. So I'm not sure what I'm asking, but so is there a relationship or between all those other muscles and your heart muscle, and there you are working to regain strength and stamina and all of that, and I mean that must impact the heart.
Sure. No, it's a good question. I'm not sure I have the absolute exact correct answer, but chemotherapy is let's face it, it's poison, and you hope that you kill more cancer cells than you kill good cells, and it's an absolute balancing act between it's an art and a science for the oncologist to pick the right cocktail of drugs that's going to get rid of the cancer and not get rid of you. But a lot of these drugs, they work on cellular mechanisms. They work on drug, replication. They work on microtubules. They work on the G cycle replication. And so obviously muscles, when they reproduce and they're poisoned, they atrophy. The heart muscle doesn't generally regenerate as quickly as other cells, but it can regenerate. But I would think, I'm just going to guess that if something's damaging your skeletal muscles, it can easily damage your heart muscle. It doesn't always present that way. We do see people with strictly, specific heart muscle damage and no other problem. But in general, it does take its toll on the whole body. I mean, that's why people, vomiting, they lose their hair, they feel nauseated, they're sick, no appetite. I mean, the whole thing all goes together. And, hopefully you can get through that. And then once you come out the other side, the body regenerates and recuperates and builds itself back. And I think this is why, it's great that the Cancer Center has so many wonderful programs in terms of diet and nutrition and a positive outlook and all the social interaction. Exercise is absolutely crucial. I mean, even after a heart attack, I could say that back in the 1950s. I mean, I wasn't practicing then. I was wasn't born in the early. I was born in '57, but the treatment for heart attacks was bed rest for 6 weeks. And the first person who questioned that was a guy named Paul Dudley White, who was Dwight D. Eisenhower's personal cardiologist. And he said people should really get up and get out of bed and start walking and exercising. He was considered kind of a heretic. He was thought to be a nutcase, and everybody kind of poo-pooed him, and he was thrown out of meetings. And but he stuck with it, and he said, no, I think this is the right thing to do. And he did studies, and that's when the CCU was born, and the cardiac care unit and cardiac rehab was born. And now we know that you shouldn't have bed rest. Bed rest is the worst thing for you after a heart attack, and exercise is good for the heart. And so he's kind of my hero, Paul Dudley White. And if I went into a bookstore once up in San Luis Obispo, and I saw his original book, and you read it, and it's very eloquently written in a very simple layman's language, English, and it's very inspirational, and it was just kind of amazing to read it. But I think the same goes for cancer. After you've been through chemotherapy and everything, I think it's very important to eat very healthy food and to exercise and to get very good sleep and, to manage stress and, all of those things are very important.
Okay. Thank you.
Sure.
And another question in the chat, what is the name of the test to check plaques?
It's called a coronary calcium scan, CCS. It's done by most radiology suites. Typically, in the past, it's not been covered by insurance, much to the dismay and chagrin of all the cardiologists who order it, because we think it's a very helpful test. It's very good for prevention. It generally runs in this community about $150, and it's kind of like a cash thing. Sometimes, I think overall you do need a prescription from your doctor, but I've heard of people calling up places and saying, you know, can I get a calcium scan? And I don't know that you need, I personally don't think you should need a doctor's prescription, but, you know, certainly, you know, if you're a pregnant woman, you shouldn't have the radiation. And so I think medical legally, the radiology suites demand a prescription. I know that some payers will pay for it. I know Blue Cross Blue Shield does not pay for it. I typically don't start ordering it until people are in their 50s and maybe, you know, if you really have a lot of risk factors, family history and risk factors, I think 40 is as early as I would go. The problem with ordering it too early is that plaque can be non-calcified. So you could still have plaque and have a high cholesterol and get kind of a sense of false security. If you come back with a calcium score of 0 at the age of 50, you can say, oh, well, I can go eat all the cheeseburgers I want and steak and fries, and I don't have to take my statin and I don't have to worry about it. And that's not the case, because you could still have plaque that hasn't calcified. The older you are, the more accurate the test is. So generally speaking, if you're 60 or 70, you have a score of 0, that's a really good place to be. Women tend to get calcified plaques a little later and less so than men, because estrogen seems to be protective of this. And once they go through menopause, they kind of catch with men and start having more heart attacks. But, you know, typically most cardiologists now are ordering these on almost everybody over the age of 50 who comes in for, I would say, screening, you know, not for everybody, but just screening. I trained at Harbor UCLA. Matt Budoff is the lead investigator. They've done hundreds of studies, actually published studies. They're one of the world's top centers in calcium scan. And, you know, based on all that, almost every community has a calcium scan, you know, place you can get a calcium scan. They're relatively, you know, universal. You can get one almost anywhere. And I think they're very, very helpful. I use it as an added risk factor. If you look at risk factors for coronary artery disease or heart attacks, the 5 major risk factors are smoking, diabetes, high blood pressure, high cholesterol, and family history of heart disease. We call those major risk factors. Minor risk factors we use are sedentary lifestyle, obesity. Yeah, I mean, those are, you know, and we call it minor risk factors. And now we realize that the calcium score is a very, very powerful predictor. And unfortunately, there are many, many people who have no risk factors, like no smoking, no diabetes, no high cholesterol, and they have positive calcium scans or scores. And, you know, we do believe that it's a genetic issue, and it's not simple genetics that, like, your mom or your father have it, mom or dad have it, and then so you get it. We think it's probably multi-generational and involves multiple genes crossing, you know, multiple lines in terms of cousins and aunts. And so, you know, there are people who, you know, the parents don't have heart disease and the child does. And, you know, go figure. I mean, we haven't figured this out yet. It's still, you know, we're still learning a lot about it. But the calcium scan's a nice way to just recalibrate your risk. So for instance, if I see a 60-year-old person who wants to know what the risk of a heart attack is, if they don't have any other risk factors and they're otherwise healthy, if their calcium score comes back very low, I'm going to say, well, you know, your risk of a heart attack is low. And I don't think, you know, if their score is 0 and they don't want to take a statin, I'm not going to argue with them. I'm going to say, well, you know, you've proven that you don't need a statin. If their calcium score is elevated and they have a borderline cholesterol, even if the cholesterol is normal, I'll still talk to them about taking a statin, because we know that statins decrease the risk of heart attacks and strokes. We don't give statins or aspirin to get rid of the calcium, and you will never get rid of the calcium. This calcium will only progress with time. What we're trying to do is decrease events, heart attacks and strokes. And even though the calcium may build and grow with time, the risk of rupturing the plaque and having a clot and causing a heart attack or stroke can be diminished by taking a baby aspirin, taking a statin, and most importantly, by eating healthy and exercising, keeping your weight controlled, controlling your blood pressure and your cholesterol. So, I don't say that everybody with a positive calcium score should be on an aspirin and statin. What I say is it's complementary to good lifestyle habits, which, I consider the most important: exercise and diet. I think those are the two. If everybody exercised and diet the way they should, I think we would have a lot less heart disease in this country. And the aspirin and statin are complementary to that. So I always tell my patient, my number 1 through number 10 recommendation are exercise and diet, and then 11 and 12 are medications, because I think you can do a lot with exercise and diet. I hope I answered your question. It's a very long-winded answer.
It's very informative. Thank you. Well, Dr. Roth, thank you so much for being with us today. Your presentation was informative. We thank you so much for being so interactive and warm and helpful. I'm going to go ahead and stop recording.